We're moving now to a conversation. The conversation will be with our panellists and then with you from the floor. We like to think of this as being a little bit like ABC's Q&A. Of course, the problem here is that I'm not Tony Jones, but you won't be disappointed with our panellists. They're a truly excellent group of panellists. But first of all, a question to the floor. Anyone recognise this? Well, a clue. I thought I would start with this news item because it's directly relevant to many people here. It's directly relevant to this faculty. Of course, the Nobel Prize for Chemistry was announced last week. It was awarded to Robert Lefkowitz from Duke and Brian Kobilka from Stanford. And their work was looking at the way in which G protein-coupled receptors work, which is a mystery to me until I heard of the announcement last week, but I understand it's the key to not just how our bodies function, how we respond to stimuli, but also a key to pharmacological interventions. So it's a case of research that some might have said was rather pure research. Brian Kobilka and his team spent 20 years looking to understand this mechanism, but having made this breakthrough, it has the potential to transform the way in which we go about seeking cures. And it's not too fanciful to suggest that perhaps one day there may be colleagues here at Monash, perhaps even in this room, who might join in a Nobel Prize. There is a connection with Monash in as much as Brian Kobilka is an adjunct professor here at this faculty. So I think Michelle can tell us more about this, but it just seems to me a nice reminder that yes, we have to ask this question: is there something we can fix with money? Is there a singular fix? Of course, there's no singular fix. Does that mean we don't need money? Well, as we've heard RJ argue, a lot of the need is in that last mile delivery. But there's also a need for research and for funding research because perhaps paradoxically, putting money into research can lead to ways of doing things economically that otherwise would not be possible, as is the case with this particular Nobel Prize winning research. But enough from me. I want each of our panellists to start with a little introduction about where they're coming from and what their answer is to this question, and then we'll take votes to award who gets the correct answer. Well, no, we'll move into a conversation. Let's just move across in the order you're sitting. So, Michelle, if you could lead us off.
Okay, thank you very much. Thank you all very much for coming along this evening and appreciate the opportunity to participate in the panel discussion. I am a graduate of Monash University from what was the Victorian College of Pharmacy at the time. So I spent many hours sitting in this hall, Cossa Hall, staring into the mural behind us, hoping that somewhere embedded in there was the answer to the exam question. It was never there, but I know the mural well nonetheless. So I'm a trained pharmacist and specialised in the research of pharmaceutics, which is understanding the delivery of drugs, not in the sense of accessing them out into people in the healthcare system, but how can we deliver medicines effectively to people? How do they get into the body and circulate within the body to have optimal effect? And then most beneficial therapeutic outcome. And so I've conducted research in looking at ways of making prodrugs of molecules where we might be able to improve the formulation so that perhaps something's not painful on injection, or a controlled release formulation of a tablet where we might be able to increase patient compliance. So maybe once a day dosing instead of 3 times a day for antibiotics. I moved on after completing my PhD here. I went to the University of Kansas in the United States for 7 years, again continuing to work in drug delivery, and then moved back to Monash about nearly 6 years ago. And at that time started to research, still in the field of drug delivery, but looking to overcome some of the challenges that are faced in global health, like can we remove the need for cold chain storage? Or can we take a medicine that's only administered via needle and syringe and change that into a form that a patient could inhale so that they could self-administer a medication rather than need the presence of a trained healthcare provider for that medication? And so that's one of the main research focuses that we have at the moment is can we deliver medicine to the last mile, to the women who are giving birth at home, who at the moment in the world, unfortunately, it's about 800 women a day will bleed to death after childbirth. But there's a drug that prevents that. It's extremely preventable and it can be treated. But that drug requires cold chain storage and needs to be administered by a trained healthcare professional. And so what we're working at doing is making that drug in a form that's a powder. It's in a simple device, low-cost device that could be provided, again, lands on the shoulders of the community healthcare workers, where they could make that available to women immediately after childbirth and prevent that unnecessary loss of life. So that's sort of the essence of my research at the moment.
Thank you, Michelle. Paul.
Yeah, thanks. I'll talk, apart from my personal opinions on the matter, I guess, from the point of view of basic research. And even though not to overemphasise it instead of alternatives in public health, as Elizabeth articulated, but basically to have an object of the public health issues. And I think for my field, I'm interested in, as Elizabeth said, in the immune response and how we react to all sorts of diseases and stimuli, but most relevant to this conversation is that of infectious diseases, which is one of the big issues for global health. And you only have to look, I think, for basic research at the simple fact of vaccination that was discovered, I think, in the 1790s by Edward Jenner, who was doing basic research on cows, who came up with the scheme of vaccination that protects so many of us. And vaccination is certainly widely accepted as a very effective treatment. It saves people's lives. It gives children a healthy start. In terms of the context, I guess, of the Nobel discovery that you talked about, I think what that in essence shows is that in the 60s, when these guys were originally researching the very basic biochemistry of how a protein interacted with its receptor, it wasn't till they were enabled by technology in the 80s, where gene cloning came into events, that they could actually clone the gene, make the protein, make it a therapeutic product, realise that there is probably a family of 500 of these type of GPCR receptors that are amongst the most druggable targets that cover solving our pain, responding to cardiovascular disease, modulating immune responses. In my own field, at the very similar time, I work on interferons, which are one of the orchestrators of the innate immune response, which was captured very well earlier. And these molecules similarly were discovered in the 50s because somebody was trying to passage viruses through eggs, which they did, and noticed there was an interfering factor, which is where it got its name. Again, not till the 80s when those genes were cloned and became one of the first drivers of the biotechnology industry. They happen now to be the treatment of choice in chronic hepatitis B and C viruses, which are major global health issues, particularly in Asia and Africa. And the sort of research we do, some of it's very similar to Michelle, and we have in fact colleagues in common where we're trying to, through basic research, understanding mechanisms, change the dose we deliver to 1/10 or 100th of what's delivered now, which will make it cheaper, to change the formulation, as she was saying, from an injectable to an oral delivery, and basically change the stability from having to keep an injectable at 4 degrees and refrigerated to something that's blister packed, available in a tablet, and much more stable and can be stored at room temperature for large periods of time. The other thing, and that's with an interferon-based modularity. The other aspect, I think, is genomics, which as Elizabeth said, again, I'm very into this technology of genomics and bioinformatics nowadays. And again, as Elizabeth hopes, sequencing people's genomes in Africa and various countries has told us why some people are susceptible to hepatitis C virus in that case, which ones will and won't respond to this particular therapy. And not only does, I think, that tell you a susceptible population and how to target your therapy, but it also means that the people who don't respond then become the subject of a new round of drug discovery to say, all right, how do we find a treatment for them? And I think that's the classic of translational research we talk about so much now. It's not just taking a clinical a discovery and applying it to the clinic, but it's also taking clinical information and redefining, if you like, the basic research agenda. Thank you, Paul.
Okay, thanks for having me on the panel. I believe there's a financial fix, but we need a leadership double fix. So if you look at HIV/AIDS in South Africa, for instance, with small money we could expand antiretroviral treatment. With more money we could create more awareness. But on such a thing, you also need leadership. So we had a president, Thabo Mbeki, who took charge of the economy and gave us 4.5% growth every year for 10 years. And in the process earns the intellectual respect of the people he leads. And then he comes out and says HIV doesn't exist. And then his Minister of Health comes out and says, no, HIV exists, but you can treat it with vegetables. And then we've got a new president now that says, if you shower after sex, you won't be infected with HIV. Now, in a country like Australia, that would just be laughable. But when you're dealing with a public that is not very educated, then it's $1 billion damage. So before we spend more money, we need to get our politicians to stop talking. We also need to get our human rights in order. So when there's gender inequality and the government is not doing a lot about it, how does a woman negotiate condom use in a relationship if she's not equal in that relationship? So these are things we need to look at before we keep injecting money directly into HIV. And you also look at, there needs to be overall socioeconomic development. So if you've got the most brilliant and most well-funded awareness program in the world, but you're trying to preach sexual awareness to a child-headed household where there's a 15-year-old girl taking care of her 2 siblings, she doesn't have much money, she can't survive. How do you prevent survival sex, no matter how good your funding for HIV publicity is? Look at the minds. These are the people whose backs carry the success of South Africa as a country. But less than 2% of minors live in family-friendly housing. So that means you migrate from the rural area to the urban areas to work in a mining firm, and you can't take your family along with you because you have to live in a hostel. So what happens then is there's a commercial sex industry building up around these hostels, largely unregulated because of the kind of people involved, and that's a public health problem right there. And also on overall socioeconomic development, as opposed to just direct funding for HIV, there was a research I led at Oxfam, and what was happening at that stage is that the government had a good disability grant system. So you've got a medical condition that prevents you from working, you get 1,000 rand from the government, and that's equivalent to the minimum wage for the domestic worker. So it was quite substantial. So what the government did was to extend these grants to people who become HIV positive and their CD4 count goes below 200, which means they are approaching the AIDS phase. But also at the same time, they begin to give them antiretroviral treatment. And the moment you start taking ART, your CD4 count could go above 200, and then you lose your grant. What then began to happen is because of high levels of poverty, people were messing with their medication, because if they recovered a bit, they will lose the government grant. We then had to come up with all sort of policy options, one of which was, instead of calling this a disability grant, give it some other name, so that you can take a holistic approach. So if I lose my job because I'm too sick to work and I recover, it doesn't mean I can get my job back. I'm going to fall sick in another 1 month. So we needed to develop policy options to cater to things like that. So direct funding at times doesn't work very well, but a holistic approach to social development works better, I think.
Okay, I come to this as a scientist and a clinician, having spent really my whole career working in HIV, and I think what I've learnt in my career is that financial investment can make an absolutely enormous difference to global health, and I think we've seen that in HIV, and I guess I want to just make it clear to the audience that when HIV was a universal death sentence in the early 90s when I first started my training in infectious diseases, and within 10 years we had effective treatments that now basically give people a normal life expectancy. So, and furthermore, those drugs are now available to people in low and middle income countries. So in 2000, when we were all enjoying the benefits of antiretroviral therapy in a country like Australia and saw mortality rates from AIDS plummet, countries like South Africa had Mbeki saying these kind of things and no access to treatment. And so there began an enormous global effort through advocacy and leadership. I think there was some excellent leadership, a whole lot of complex interventions that allowed the introduction of antiretrovirals into low and middle income countries. There are now 8 million people on treatment, which is about 60% of people who need it. So I I adore Elizabeth, and I don't want to, ruin that relationship in any way, but I would disagree with her about the successes in Botswana, because I think if she had gone and visited 10 years before, she wouldn't have just seen the wards, full of people dying of HIV. She would have seen the whole hospital overflowing with people with HIV. So yes, we have the tools to act. People actually say we now have the tools to end AIDS, because if we put people on treatment, they actually have a normal life expectancy, they don't get sick, and their infectiousness is reduced by 96%. So if we could get anti-HIV drugs to all people who need it, we could end the epidemic. Now, of course, the implementation challenge is huge, as we heard from Ajay, and we need leadership in order to do that. But we have got part way there. Mortality has significantly reduced in countries like Africa. Life expectancy has significantly increased. So I think there are still many, many challenges, and Loa highlighted many difficulties that we still face, but I don't think we should underestimate the enormous advances we've had, and that's really come through science and innovation and the belief that you can do it. I think people thought for many years, yes, great drugs, therefore the developed countries will never be able to get low-income countries to take them. Well, we've all been proved wrong. And now in the next phase, I think, of the HIV epidemic, we're learning that there are new and improved ways to prevent HIV through circumcision, through taking anti-HIV drugs, using microbicide gels, which are anti-HIV drugs that women can apply in the vagina around the time of sex, and a female-initiated prevention strategy that can reduce transmission. So there's just huge amounts of development, and that all comes from investing in science and innovation. There's a huge challenge to implement it, but we have come a really, really long way.
Thank you. Well, Ajay, you hold the Finkel Chair in global health, so you're at the peak of your career. It's impossible to imagine where you would go beyond here, but just imagine for a moment two things. One is that the global economy has turned a corner and we're in a sort of a purple patch. Things are going very well, and you've been appointed head of the World Bank, and you've been charged specifically with fixing global health. So, we've got the money now, now's the time to go for it. What would you do? And I want our panellists to respond and see whether you're getting it right or wrong.
Difficult question to answer, because I'll be worried about how long I'm going to survive there.
Better stay at Monash.
Okay.
Yeah.
I think what one has learned over the years is that that in fact one has to give much more primacy to people at the ground level. I mean, one thing I've learned over the years is that most of the programs that are actually successful tend to be ones that are led by people at the ground level. That is, either are accountable to or are actually implemented by people in rural areas or urban slums or whatever. What does that actually mean? I certainly don't expect hospitals to be run by people living in rural areas. What I do expect, however, is a degree of accountability in terms of resource allocation, a degree of accountability in terms of how services are provided, whether it's primary healthcare services, whether it's the community health worker working out there. So the programs that I would sort of fund and support essentially would be ones that allow for a much greater participation of local individuals. I mean, I used to laugh sometimes when I used to have World Bank counterparts sitting with me when I used to be a small-time non-profit consultancy worker. They would say, we've got the money. The government will do whatever we ask them to do. To me, that was shocking. I mean, the government of India willing to do whatever these guys say, these new PhDs from wherever? It was a bit of a shock to me. But I think sort of that lesson apart, I think what I've found over the years is that the biggest single problem seems to be a mismatch between what we think we're providing to these poor little, at the sharp end of our last mile problem. On one side, on the other side, there's a whole bunch of people who actually are not consuming the services you're providing them. There is almost like a mismatch in what you're providing them and what they're getting. So I would sort of argue that in favor of more community-led programs, many more of those, including whether it's delivering the sort of intervention Sharon's talking about or whether it's Michelle's talking about. I think that's what I see as the future.
Okay, that seems hard to argue with. I wonder what the panellists have to say about what they would want to see when, you know, you remain friends with us as head of World Bank and you'll be seeking advice from us, so what input would you have for the new head of the
My
World Bank?
input would be don't forget your fellow panellists as head of the World Bank.
You better become friends with Jim Kim then.
Right, okay. But I was fortunate to spend the last week in rural India.
Yes.
And we were based out of Lucknow, which is in Uttar Pradesh, has very high maternal mortality rates. And what we wanted to do is spend a week and understand what are the attitudes towards an inhaled medication. Is that an acceptable way of receiving medication? We know that in India, an injection is viewed as a very strong medicine, and you can trust the strong medicine. And they're familiar with taking tablets. But have they seen an inhaled medicine? Would they use an inhaled medicine? Would there be a preference for intranasal over oral inhalation? And so we spent the week there, and again, it costs money to do that type of research, and fortunately the VCP Foundation, their focus of their annual appeal this year was to raise money for the Inhaled Oxytocin Project to allow us to go out in the field and do that. And we learnt such incredibly valuable information, and it's understanding the community and getting the community engagement of that. But we found out that intranasal is just not a route of administration that would be acceptable. It's associated with direct delivery. If you inhale it, it's going to go to your brain and have mind-altering effects. And so it just culturally wasn't going to fly. And so that was important for us to find out sooner rather than later, rather than spending the money doing the development and then finding out it's not going to work. We also found out that inhalation is very acceptable in that they use steam inhalations for a cold the same way that we would, and that was viewed as a cleansing medical process. And so they were very receptive of the idea of an inhalation. But what we also learnt, which was fascinating, was that if we said, here's an inhaler, it's a medicine to stop the bleeding after childbirth, well, that's just not going to work, because it's so important that women bleed after childbirth to remove the pollution. They've had a 9-month build-up of soil and dirt in their bodies, and that bleeding needs to occur. And they don't associate blood loss with death after pregnancy. What they do know is that sometimes women die from weakness after pregnancy. And there isn't a link between the fact that blood loss is contributing to the weakness. They just know that a woman needs to go into a period of isolation for 10 to 12 days after childbirth to remove that build-up of pollution. But if we were to give them a medication and said this will help you get your strength back after pregnancy, then we get a completely different acceptability. And so I think that, you know, my response to is there a financial fix? I mean, absolutely, finance is essential, but it really needs to be used in conjunction with so many other approaches that allow you to understand how is it implemented. And you need to get that knowledge as soon as possible so that you don't find that you've spent millions of dollars on a clinical development project for a product that just socially and culturally won't be accepted.
Going back to those problems you raised, I mean, they seem really a little bit overwhelming, but where would you start to address some of those challenges? What, if you were Minister for Health in South Africa, for example, what would your priorities be? What would you try and do?
I'll fire the president. I'll start with that, but
Okay, you're the president then. Put him make me the president. You should be.
I won't whine. But I like what AJ said about we need to start listening to those on the ground instead of just talking at them. And even the issue I raised about people messing around with their antiretroviral treatment, we got that information from those on the ground. They were the ones that came to say, well, this is your policy and this is what we're saying. Then we began to investigate further. So we just need to keep people connected with those on the ground. That's the only input I have on that.
Can I add a little
You certainly can,
qualifier
Ajay.
to what I said?
Yes.
Chances are that if I were to do what I said just now, the World Bank would probably fire me because I wouldn't be able to recover any money.
Yes, that's a practical problem in terms of where economics meets policy, isn't it? Are we going to see a shift in thinking about that? Are we moving into a more enlightened approach to investing money in health?
At the bank or generally?
Generally,
I think they are beginning to see that, and I think it's sort of, if you look at what's happening over the last, I think, 10, 15 years in the global funding arena, I mean, you can see it happen. You had the Commission on Macroeconomics and Health led by Jeffrey Sachs, and I actually took the time to sort of read it again today, 10 years later, and it's quite remarkable that, yes, it talks a lot about how much money the world needs, but a lot of time was spent on actually the right kinds of programs, implementation issues. And while in the end, I don't quite know what happened to the recommendations. Certainly the Global Fund on AIDS, TB, and malaria came out of it. But certainly, even as far back, 10 years back as well, I mean, there was increasing appreciation of the fact that technology and implementation have to go hand in hand. That one without the other actually is a serious problem. Then, of course, not always, of course, as Sharon very well knows, I mean, the Gates Foundation gutted the health systems element of its funding strategy, I think last year or the year before. And certainly all funding, and they made a decision, I believe, to fund directly basically technological innovations. And there's no harm in that. I happen to also know that there are people within the Gates Foundation who have actually surreptitiously funded health systems projects. So because they're essentially aligned with that particular perspective. So all said and done, I think there is certainly appreciation of the health systems perspective. And the reason, and in fact, I should say the reason there is that particular perspective that's getting ascendancy is because actually the leading funding agencies for that are not the World Bank or the Gates Foundation. They are the countries themselves. In fact, the big push towards health system investments are coming from China, from India, from even Malaysia is talking about it. So in fact, that's where the big changes are going to come from. And in fact, in that sense, at some point, there will be truly country-led innovations in the health systems world. And perhaps that's where the future is. But I wouldn't know right now.
Yeah, Sharon, I wonder whether you're seeing that beginning to happen in HIV work.
Yeah, in funding anti-HIV drugs in low and middle income countries, that largely came about from great leadership, I think, through, in fact, George Bush made the single biggest investment in HIV in any single disease when he set up what's called PEPFAR, or the President's Emergency Relief Fund, which basically propelled the availability of anti-HIV drugs, and joined by the Global Fund as well. And the total cost of providing those medications is around $15 billion currently. But in many countries, there are now increasing proportions being contributed by the local countries. Some countries better than others, but I know South Africa commitment, it's not entirely, and in fact now how money is given is that there will be increasing partnership from the donor countries. So within the HIV world, those models seem to be happening. They're not happening everywhere, and obviously operating in an environment with the global financial crisis, and some countries may never be able to do it, but many countries which we thought may never be able to do that. South Africa, as I said before, is now giving a certain percentage that's covering that, and their goal, I think, the strategy through the Global Fund is that countries will eventually become autonomous in maintaining that. The other approach, of course, you can use is thinking about is innovation and investing, thinking about the future. And at the moment, once someone's on anti-HIV drugs, they need to be on it forever. So, you need to take on this responsibility that once you start treatment, people will need to take drugs for 40 to 50 years. So we have to think now about ways that we're going to get people off drugs, and that's really the sort of work that we're doing at the moment, and many are now become really interested in, is understanding the science. Could we got to a situation of tremendous drugs that have totally reversed mortality and return life expectancy to normal, but you need to be on them forever. So can we get a way to get people off drugs so maybe you could treat them for 5 or 10 years but not 40 or 50 or 60 years, and that may make a very big difference to the burden that many countries face in maintaining. And it's not just money, it's huge amount of issues with personal health with managing chronic illness, being on drugs forever. It's a major, major challenge.
Paul, are we going to move beyond the current sort of dependency on drugs and the current models in the next 20 years? Are we going to see breakthroughs?
I don't think we'll move ourselves from the dependency on them. I think the nature of them will change as technology brings us along. And I think we always have to be aware, as AJ said at the start, of surprises, or whatever the word he used, because not only are they sort of sociological, but they can come in the form of new bugs, whether it be multi-drug resistant bacteria, emerging viruses. You know, we've had scares with SARS, with swine flu, which didn't end up being very virulent, but certainly spread very quickly. And I think there are great examples, really, of how technology can sort of help us. I mean, and really in the initial breakthroughs for HIV, you know, it's amazing how fast these things with great microbiology can be, the bugs can be isolated, they can be sequenced, you can make a protein, you can make a vaccine. You know, CSL do it every year, you know, change their vaccine to accommodate what the latest flavour of the disease is. So I think technology will help us change to and adapt to, you know, different profiles. And, you know, I think as Sharon said, you know, dependency on drugs will bring different diseases. You know, as soon as you cure people with HIV, all of a sudden you have people with HIV, you know, getting ageing diseases prematurely and so forth. So the nature of not only cures, but patient care and public health issues will be very different, I think.
Michelle, you know India fairly well. Do you see things changing there? Are you optimistic that some of the problems we associate with delivery can be overcome?
I think it was fairly evident on this last trip that things are changing, but so much of it is dependent on education and getting that message out more broadly. And it's fascinating with vaccines. It's been so successful in implementing cold chain storage that we visited multiple healthcare clinics and they had refrigeration and the vaccines were kept at 4 degrees or between 2 to 8 degrees. But there was a whole range of other medications sitting on the shelf right beside it, all labelled store between 2 to 8 degrees, but they're not vaccines. So they're not part of the program and they're not allowed to be in the refrigerator. And so there's just that need to bring people together and to really communicate, and there has to be a way that you can find space in that refrigerator for the other medications. And so I think it's a big problem, and it's more than innovation and it's more than technology, but it certainly needs to be a combination of all of those.
Yeah, that's a compelling image, isn't it? Getting a larger fridge, or at least helping people to understand they need to put it in the fridge. I'd like to encourage the audience to think about questions they might like to ask. I'm sure you've got things to contribute, and you've probably got, this is a very expert panel, you've got very specific questions for the panellist. Is there anyone with a, yes, there's a hand going up there already.
This is a bit of a controversial question, but, oh, thank you. Can you hear me? I'm loud anyway. I wonder if technology can actually sometimes mask the underlying issue. So that, for example, let's say intranasal OxyContin, can that actually mask the fact that, in fact, these women don't have healthcare professionals and they need healthcare professionals, or they should have the right to have a healthcare professional present at their birth? And therefore, by giving the technology, we're actually masking the underlying problem. Or with antiretroviral medicines, that maybe women are being infected because of the prevalent gender inequality that lies there. Therefore, by treating it and just masking it, we're sort of like avoiding the actual issue that's underlying the whole thing.
Michelle,
You can do oxytocin.
All right, thank you. I will comment on oxytocin. And yeah, it's a good point that you raise, and absolutely every woman does have the right to give birth in a facility with trained healthcare providers, but I think we need to be aware of the cultural issues, and that there's a lot of evidence to show that even if there's a healthcare facility 50 metres down the road, women in certain societies will choose to give birth at home because traditionally that is how they wish to give birth and that is their cultural norm. And so we need to look at ways also to empower the women to let them make the choice, because they're not the decision makers in the family. And so it's not the woman who will give birth and think, oh, something's not right here, there's copious amounts of blood that shouldn't be happening. She'll have to wait for consent or recognition from her husband. Okay, yes, we'll spend the money to get the transportation to take you to hospital. Or it'll be the mother-in-law who might be able to make that decision that you need more transport. And so I think it's also looking at empowering the women to take some decisions and control for their own health. And I think it's a huge issue, the gender imbalance and discrimination that we see. And one of the most sort of tragic things that I've seen in the labour wards is you'll go around and look and there'll be 10 women holding beautiful, perfectly healthy babies, and there'll be half of them that just have a look of devastation on their face because they've just given birth to a girl. And that's just, it's a huge burden on the family. There's a dowry, they can't work, they can't earn the same sort of income that a son would work. And, it's a confronting thing to see when you're out in the field.
Yeah, I mean, I think it's an excellent point, because it's just taking the tablets at the very tail end, and there's all of these other complexities just to get access to people to take drugs that we know that work. And the first thing is just being tested, and there's still so much reluctance to be tested. We shouldn't underestimate the enormous stigma of HIV, that people just don't, even in places where 50% of people are infected. So every second person is infected, and yet there's incredible stigma. So just to get tested, to come back and get your results, to stay in healthcare and find out when you need your drugs, then to take your drugs and keep coming to the doctor. So there's so many steps before that need to be addressed. So I don't want to have oversimplified the issue by saying we've got great drugs and it's going to solve the problem. There's all of these very complex factors, and there's no doubt, Elizabeth mentioned it earlier about the feminisation of the HIV epidemic, and it's mostly women, and it's mostly have poor education and poor access to healthcare, and all that really compounds the complexity of solving the problem.
Ajay, thanks.
I can't resist responding to that. I think in general, I'm in favour of any fix, even if it masks problems, simply because the option is nothing else. So I certainly will come down on the side of technology if it's affordable and it gets to people. What I get concerned about is if in fact there are long-term implications. So for example, if you go to provide some, let's say, antiretrovirals, and then people don't sort of continue with the treatment, which leads to long-term social effects, resistance and so forth, then I would be worried about it. But if it's a purely like a one-shot technological gift, I'm perfectly fine with it, simply because the option is worse. And to fix this implementation, in fact, let me take this as an opportunity to say, look, we need to do much more work on, or at least research, if you will, on this whole implementation area. But while we're waiting for that lovely research to come out, I would not sort of favor sort of worrying about whether people are getting access to a particular superior technology.
Any other questions there? I'm sure there must be. Alan.
Look, thanks very much. We've heard a lot about how science and technology can perhaps help improve healthcare delivery. We've heard, and it's a really big plus, whether it's the latest antiretroviral drugs or a different drug delivery mechanism. We've heard a lot about the importance of education on the ground, so that people understand the need to come back for treatment, or the importance and the value of accepting the treatment that's 50 yards down the road. So those are both big pluses. Another way to achieve a plus is to reduce a negative. And one of the enormous negatives that is implicit in the word financial is corruption, the corruption that takes away the money from the system. So I'd just like to get a sense from some of those who've been there, how important it is to, or just how big an impact does corruption have on reducing what you're trying to achieve, and what, as healthcare professionals, you can do or recommend can be done about it.
Yeah, that's the $64,000 question, isn't it? You must have an answer to this, I'm sure.
Yes, I do.
Apart from just sacking everyone in government, we've got to come up with a solution.
Yeah, corruption is a big issue for donors, because you build a business for 30 years, you want to donate some of your hard-earned money to a community, and you want to be sure the money gets to the people it needs to get to. And that's difficult when there's corruption, and not just corruption, but mismanagement. So I don't necessarily need to be putting the money in my pocket, but if I'm wasting it, then it's also mismanagement, and we need to deal with it. And usually there is a way around it, where it will change as your context changes. So for instance, in Nigeria in 1988, they had the highest incidence of guinea worm in the world. And by 2009, it was 0. And that was largely due to funding from the Carter Center in the USA. So that's the organization of former US President Jimmy Carter. And in 2010 or 2011, what has now become a highly cited journal article was released to discuss the success stories about this particular program and what exactly they did right. And one of the things that stood out for me is that they hired a former head of state who had the political respect in the country, who the people highly valued, to be the face of the program. So with them serving as the face of the program, embezzlement and mismanagement became a bit more difficult for the more junior political officials, if you know what I mean. And all over the world like that, there are pockets of success wherever you go. What I'm not sure of is if these stories and the lessons from them have been drawn together in a way that donors can easily access them. And I'm hoping AJ will task you with that.
I mean, corruption is a serious problem. I mean, there's no point kidding around it because it's there. It's staring you in the face. I mean, I come from a country which is basically, I think, is going to soon become the corruption capital, second to Nigeria, of course. but so I mean, let's talk about how important is it. I think it's ubiquitous. In fact, the health ministry, certainly in India, is known for being a parking spot for all the corrupt guys around. So it's there. There's money to be made in drug contracts. There's money to be made in fact, at least you saw drugs next to the fridge. That's that's remarkable as well. But you might not even see the fridge, by the way. So in general, at some level, I believe that not a very, but certainly only a portion of the money allocated by ministries of health ever actually gets down to the person. In fact, one number that the former Prime Minister offered in India was 10%. So that's a pretty big chunk being taken off before it even reaches the people who need it. So that, in that sense, I think if you were to ask me, what is the biggest single thing that people who work in the area of global health could do? I would say if they could even address 1/3 of the corruption, that would be a major achievement. So have people tried? I mean, I thought I'll just share a few examples of what I would say good case studies of this. So one thing that people have tried, and this is not in the context of a health program, it's in the context of something called the National Rural Employment Guarantee Scheme in India. It's an employment guarantee scheme for people who, for the poorest, who are sort of given 100 days of work if they don't have a job. It's guaranteed by the government at a fixed rate, even if they have to dig holes and fill them up, 100 days of work they get. But, so what of course, but the corrupt can even get there, so they have developed fake employees, fake roles, and so forth. So what they have tried to do actually is to have a social audit system where they actually have villagers coming face to face with the person who dispenses the money and sort of have almost an open forum where the person has to announce who got the money and the person receiving it, who's supposed to have received it, can deny it. And that has led to a lot of embarrassments, of course, because, I mean, imagine you have in some case. So yes, there was a lot of corruption initially, but now I've heard of stories where the person handing out the money has been sweating in public because people have said we didn't receive the money. So, I mean, at some level, I think ultimately, and this is what I mean ultimately, if the person at the receiving end of the corruption is directly not involved, I'm sorry to say the program will not go away because they have no vested interest in it. They have got to feel that they have an interest in it. And in the case of the employment guarantee scheme, certainly it's their money if they could have gotten it, but they didn't. So there is certainly so I sort of think of these are the programs. I mean, this very, I would say this is right at the beginning of what might go on. And of course, you can count on, currently in India, of course, we have a massive anti-corruption movement going on, where they sort of every day they have a new expose of $50–40 billion. But I think this is high ticket. What we really need are small stories at the community level, which sort of again and again bring out what corruption is, how to, I mean, and these are examples. Social audits like one example that sort of come to mind. You could have other, of course, you could have random patients coming in and sort of, and people sort of checking whether in fact they were treated or not. Now, the other thing that India has been doing, which might also work, is this whole business of the smart card. So as part of a fairly large-scale national insurance scheme for the poor, they've been basically getting hold of people's biometrics on a card. And that's the person and the family. And so when they go to a hospital, they know exactly, and the iris and everything. So it's better than the US Homeland Security, by the way. It's that good. So they basically have it on record, and while it could be that there could be some fake people even there with those fake fingerprints and so on, but it's unlikely. Let me put it this way. And certainly, so this particular approach has also been, I mean, the government is thinking about it and using it for other public service programs. So my guess is technology. This is an interesting example of technology marrying a long-standing problem. You might say that that's the beginning of a process. I mean, who knows how it works out. And I would also argue that part of the reason there be so many recent scams that come out in India is partly because of a series of new institutional developments, including technological stuff, as well as something called the right to information and so forth, where people can sort of ask about what happened to a particular program, who benefited from it. So I would say this is a major problem. It's not going to go away in the short run, but there are some baby steps that are being taken, which I think have potential. But I think a lot of work needs to be done to see how effective these are. I think the answers are still out.
I'm just going to follow up on that. I'd be really interested in your opinion of whether it's the sole responsibility of government to deal with public health, and whether there are other models that we should be looking at. And I know the Global Fund that give governments fixed amounts to spend on antiretroviral programs. In some countries where there has been corruption and has been a problem, one country in our near neighbourhood, the money was taken from the government and given to a large mining organisation who they felt could administer the ARV programs far more efficiently. So I wonder what role there is in non-government, private sector in public health.
I think a very important role. Let me put it this way. There are many examples of private organizations that have got a very strong track record.
I'm not saying there's no corruption in private organizations.
No, not at all. I'll give you both the pros and the cons as how I sort of think about them. I think you have, for example, the BRAC organization, Bangladesh Rural Action Committee, which has done a phenomenal lot of community health work, rural health work in Bangladesh. I don't know how many districts it covers, but probably several million people it covers under its programs. So certainly BRAC is a fantastic example of in fact, you might think that in Bangladesh, in fact, it's the non-government players who have a bigger role in the health sector than the government. So, and of course, I mean, I can clearly see private initiative being an important factor. In fact, if you think of what's happening in India's health services sector right now, the government has a health insurance fund, which then allows private and public sectors to compete for. So actually people can either go to a private hospital or to a public hospital, and that apparently has improved quality in both the public and the private sectors. And the poor people love it. So certainly I would say those are good examples. My worry, of course, comes from handing over everything completely, because in the end, the private sector or even BRAC are not really accountable. Who are they accountable to? So the issue of accountability comes in. But other than that, I'm all for it. I think to the extent that we can harness their incentives in ways that can sort of, for example, what people call somewhat misleadingly public-private partnerships. I'm perfectly comfortable with the idea of private sector delivery of services, perhaps matched with public funding. I mean, the reason I keep coming back to public funding is because public funding, for many of these items have strong public good characteristics, that they have a strong social benefit element. So you won't find money coming in easily from other sources. Either it'll come from donors or from the government. And you can't expect the poor people at the bottom of the bottom being able to fund it themselves. They can contribute a little, but not a lot. So I mean, I see the government role in financing still being there, but I see a much stronger role for private sector in delivery of services.
Great. We're almost out of time, but it was a quick response from Aloge, and we'll very quickly deal with a question at the back before we wrap it up. So, but Aloge, you wanted to make a quick
I'll just
final
add to
comment.
that. Sharon was talking earlier about partnerships, so governments doing their own role in the overall funding, and I want to speak a bit about that in terms of international funding and corruption and mismanagement. So, for instance, we know in South Africa that 1 in 3 pregnant women are HIV positive, and we also know there is PMTCT, which is a treatment that you take and will reduce the chances of transmitting the disease to your child, and reduces the chances by 95%. So that's a proven intervention. And we also know that the government itself is funding 80% of treatment. So that's something that political will has been demonstrated, effectiveness has been demonstrated. The government is taking care of 80% out of 100%. Then I think an international donor can help with the remaining 20% and be confident. But if you look at something like research, where the government is only doing 5% of the HIV funding that is needed, I'm not going to put my 95% in it. because then I'll take the larger fall.
Good point.
Thank you. Very briefly, Helena Teed from the School of Public Health at Monash University. Firstly, just to recognise the fantastic exemplar of a basic science researcher who's gone to the coalface, done the formative research looking at the socio-cultural barriers to overcoming implementation of their drug delivery device in the field, and how rare that approach is across the whole cycle. And on that note, the question really is to the panel, how do we increase the recognition in the World Bank and in the funders of research, including in HMRC and the like, for the critical need for formative research to inform how we develop these drugs, how we develop our different strategies in public health situations to change practice, and indeed how we implement them? Because the cost of formative and implementation research is relatively cheap compared to discovery research and has the potential for great impact. And yet at this current stage, that's not necessarily recognised, and the investment to undertake formative and implementation research is very challenging.
It's a very insightful question. Ajay, you're head of the World Bank, but I'll come first of all to Michelle.
Please do.
Yeah, I wish I knew the answer for how we sort of raise the profile of that. Certainly, I think we've made some progress with AusAid, at least recognising recently that part of their strategy should include funding medical research. The budget that they have for it is minuscule. But they're looking for the opportunity to link in with NH and MRC to try and get some of that more basic research that can be sort of funneled into something slightly more applied. But certainly if anybody's got any ideas, I'm more than happy to listen.
Paul?
I suppose, Helena, don't we? We spend a lot of our time lobbying, and each of us have to do it for our own sectors. I mean, I think if you're talking about that more translational aspect, I think the recent McEwen review was fairly positive and fairly different, I suppose, from past reviews and outcomes into indicating perhaps the importance of that. I mean, it remains to be seen whether the government will take notice of that and the rest of our pleas, I guess. But, you know, I think it's really important if Australia is going to play a role in global health. You know, it's got to also operate from a position of strength, and, you know, we shouldn't be constantly battling to keep ourselves, you know, just below, you know, well below, you know, the average investment. You know, out of all the OECD countries, we're about number 14, and we're actually, you know, reasonably well below the average. And, you know, I think that's a cultural issue. You know, it's a political issue, it's a voting issue, and I guess it's part of our job to get out there and lobby and make sure people who care about it know about it and make it known.
Yes, I want to raise the question. Actually, I've been studying biochemistry, doing research in using only one. I was one lucky specialist student to use the only one HPLC machine we used to have for natural medicines, and we had to wait long hours to get the results back from other developed countries like Australia, Germany, and other countries which help us. So even after we come here, and as researchers or people who live in here, facing our own problems as well. So we are far away from getting resources as well as making the link between the available education resources from here, and any postgraduate researcher would understand when they go back to their countries how far away what's available here in Australia, and to implement that in their hospitals. So I hear from most of my friends who have gone back to serve their own countries and how helpless they become, and they literally give up. And they struggle to survive on their own education journey to pass on to their children, and they are on the struggling curve. So this is non-ending, and 16 years I have spent in Australia, so I'm in a philanthropy or whatever. I'm trying my best to have, as we said, like hard-earned money or whatever giving, and so we are in a real problematic time. What is the Australia's role, or countries like Australia, to make that bridge?
A very quick response from the panel.
I don't have a good response. It's a very difficult area, as we've been saying, to I guess, apportion all the funding that you've got to the different elements, and we've heard how important it is to, you know, educate people at the coalface and put efforts into there. And I think what you've done is just highlight another need with it, and it's a very important point that we not only resource people with information and skills and knowledge, but the infrastructure that goes with it is equally important. And I guess if that can't come from national resources, then I mean it has to be part of the international effort for resourcing these activities.
We're just getting started, but we have to finish, so I'll pass to Professor Mitchell.